Hello, everyone, and welcome. We are pleased to have you join us for today's Answers from the Experts program. My name is Laura Garman, Education Manager with the Cutaneous Lymphoma Foundation. Before we get started, I wanted to go over some housekeeping. We have received your questions that were submitted during registration, and the experts are looking forward to answering them. If there are any additional questions you would like to submit, please use the Q&A tool to enter those rather than the chat itself. This program will also be recorded, and you may view it on our Cutaneous Lymphoma YouTube channel. I also would like to thank our individual donors and funding partners for making this program possible. We couldn't do it without their support. This is how we are able to produce webinars, patient forums, materials, and other educational programs. We are so pleased to have two experts here today for our session. First, I would like to introduce Dr. Cecilia Larocca. Dr. Larocca is a dermatologic oncologist at Brigham and Women's Hospital with appointments in the Centers for Cutaneous Oncology and Melanoma at the Dana-Farber Cancer Institute, where she specializes in the care of patients with cutaneous and peripheral T-cell lymphoma. At one of the nation's leading centers for CTCL, she leads and contributes to clinical and translational research focused on improving treatment outcomes. Her work includes serving as a clinical investigator in therapeutic trials, coordinating genetic profiling of CTCL samples, and supporting a large observational study through data and specimen collection. Additionally, I would like to introduce Dr. Lubomir Sokol. Over the past 2 decades, Dr. Sokol has directed both clinical and laboratory research focus on T-cell lymphomas and leukemias at Moffit Cancer Center. Since 2004, Dr. Sokol has served as co-director of the Cutaneous Lymphoma Multidisciplinary Clinic, the largest CTCL referral center in the southeastern United States. He also directs the large granular lymphocytic leukemia clinic, one of the nation's leading clinical and research programs devoted to this condition, and has conducted numerous studies on LGLL. His work has been published in major hematology journals, and he collaborates with research groups across the country and internationally. As director of the Hematology Oncology Fellowship Program, Dr. Sokol has also mentored many physicians pursuing careers in malignant hematology. Dr. Larocca, Dr. Sokol, thank you so much to both of you for being here and welcome. We're thrilled to have you. And before we get to our first question, a reminder that Dr. Larocca and Dr. Sokol are here to answer questions about cutaneous lymphoma based on their own patients' experiences and knowledge, and they're not offering second opinions. Any specific questions around cases should be directed to your own care team. And with that, thank you both. Welcome, and we are ready for our first question.
Hi, Laura. Thank you so much for having us here.
Thank you for being here.
Hi, Laura. Thank you for inviting me.
Thank you, Dr. Sokol. What is the effectiveness and side effects of retinoids besides height control and hypothyroidism?
So retinoids, or medications like isotretinoin and acitretin, are in the vitamin A family. They have been around for decades and have been used for patients with CTCL. With that said, there aren't great studies where we've prospectively followed a large group of patients to have sort of really good numbers behind how effective they are. But in the real world, if you take sort of large centers who've used this medications, some people might report their effectiveness as high as 60%. But in practice, that might mean that maybe 80% of patients who get an improvement have 50% improvement, whereas there's closer to like 20% who might get a complete response. So it's hard to predict in any given patient how one will respond to these medications, but it's certainly well worth trying if it's something that your doctor recommended. The side effects are pretty predictable because it's used quite a lot in dermatology. The side effects most often are dry skin. About 90% of patients get dry skin. But aside from the dry skin, many of the other changes are often detected on the blood work, just as you mentioned. High cholesterol, less common. More often, it's high triglycerides, which is not something that makes you feel uncomfortable, but can be detected and only worrisome if it's very, very high. Aside from that, some patients might feel that they have dry eyes or a little bit of achy joints. But again, it's hard to predict who's going to feel those sort of lesser common side effects. Photosensitivity is sort of the last side effect that's important to be aware of, as they often get combined with phototherapy. So you want to make sure that the doctor who's prescribing phototherapy are aware if you're going to be starting one of these new medications.
Great, thank you for that. Another derm-focused question. In the context of a cutaneous lymphoma, can I get laser surgery or red light therapy on my face? And what about facials?
Yes, I would say as long as you don't have active lymphoma on their face, I would say that the risk of infection from any procedure is fairly low. And so I think it's perfectly reasonable to get cosmetic treatments, including facials or red light therapy, which is sometimes used for medical reasons. There's a vast range of different lasers that can be done on the face, so it's hard to know which one here is being asked on, but as long as it's not on lymphoma directly, I would say in general, it should be fine to do.
Great. Thank you so much, Dr. Larocca. What are the most critical things you should watch out for when diagnosed with Sezary syndrome?
Sezary syndrome is practically leukemic. It's T-cell leukemia based on most recent classification of cutaneous T-cell lymphoma. So it's not anymore included among CTCL, like mycosis fungoides. I would say initially with patient present, very frequently they have been misdiagnosed for sometimes several months or even years if a disease behaved indolently. So they have so-called erythroderma. More than 80% of their body is affected with practically skin lesion. And they have obviously colonization with staph, and I would say most danger, obviously complication of this disease is systemic infection. They obviously have a lot of pruritus, itching, so sometimes scratching can also introduce bacteria infection, so they can come also with infected wounds. So these are, I would say, most somehow worrisome initial complications or presentation of patients.
Thank you for that, Dr. Sokol. Vaccine-related question here. What are your recommendations on receiving the shingles vaccine if a patient has active CTCL lesions that are under management?
I think this is a great question and we get it often. So the shingles vaccine is a live virus that's modified. It's a great vaccine, and anyone who's had shingles knows just how important it is to prevent it, because it can be so incredibly painful well after the shingles has resolved. And I do think patients who have CTCL, especially more advanced stages, are at increased risk of getting shingles. And so I do encourage getting it. The only caveat is that I would not have the shingles vaccine directly injected in an area of active skin disease. That would be the main thing to avoid. But if it's under treatment, or if there's sites of disease other than where the exact injection is happening, that would be the only thing to avoid.
Thank you for that. I have CTCL and I'm on Targretin. My doctors recommend radiation as my next step. Has the combination of radiation therapy along with Targretin been a successful treatment over a period of time?
To be honest, I don't remember any good clinical trial which would combine radiation and Targretin, but we have been obviously using, for example, focal radiation and in patients who have been already either on Targretin or interferon. So there are certain agents which can somehow sensitize skin to skin damage if you would combine it either with UV light or radiation, but Targretin is not one of them. Furthermore, we have been using lower dose radiation now, so we have not noticed any adverse skin reaction if you combine radiation with Targretin. But uh, talking to our radiation oncologist, unfortunately, right now we don't have any good radiation sensitizer to use together with radiation, and possibly even use lower doses of radiation than we have now. Our solid tumor colleagues, they have cisplatin, but obviously cisplatin would be too toxic to use in patients with cutaneous T-cell lymphoma. So yeah, you can combine it without increasing side effects, but whether it help towards skin lesion, it's unknown. Obviously, it may help if patient continue, for example, on maintenance Targretin. It may help that patient is not developing either progression or new lesion elsewhere, not in that radiation field.
Yeah, and I would agree with Dr. Sokol. If someone is on fixaritine and, 80% of their body has improved, but maybe there's just one stubborn spot, that might be a great reason to add, radiation to that one stubborn area while keeping fixaritine on because it did so well for the rest of their disease. So it's really unique to the patient case, but there's no theory behind the both together being sort of an exceptional treatment rather than doing one at a time. So it's really, based on the patient at hand.
Thank you both for those answers. Another treatment question. I have been receiving infusions of Mogamulizumab. My oncologist has me started on low-dose methotrexate and has mentioned possibly added low-dose interferon. How might interferon be added benefit in this regimen?
Yeah, this is definitely, again, very interesting question. I tell you our practice. We usually do not combine low-dose methotrexate or interferon in patients who really need mogamulizumab. And I would say most of our patients who receive mogamulizumab have either stage B1 or B2. I would say majority have B2 stage. Yeah, there are patients who may get first-line therapy where you use extracorporeal photophoresis combined with methotrexate or with interferon. I have seen patients like that, but in our institution, we usually start patient on ECP because it's FDA-approved frontline therapy, and if patient shows excellent response, then they may not need anything else. And then if we don't see after a few months good improvement or we don't see reduction of circulating Sezary cells, then we obviously add mogamulizumab and continue on combination of ECP plus mogamulizumab, which can clear probably majority of our patients. So we usually do not combine two immunotherapies like interferon and mogamulizumab.
Very good to know. Thank you. Next question. I'm a stage 4 subcutaneous panniculitis T-cell lymphoma and HLH survivor. I would like to know how rare this is, as I have hardly found anyone with this type of cancer. And are there research findings about this type of cancer, along with information on lifespan when diagnosed with this type of cancer?
Yeah, this is definitely one of the most interesting cutaneous T-cell lymphomas, at least to my knowledge, because even though in some patients it can trigger a life-threatening complication, which is lymphohistiocytosis, sorry. Uh, it behaves I would say in majority of patients who do not develop HLH, it behaves indolently, and most of patients can be treated with immunosuppressive therapy. Cell type are cytotoxic T cells, CD8 positive T cells. So, and we use similar approach in in patients who have also cytotoxic T cell leukemia called LGL leukemia. So there is, I would say, parallel how we approach such clonal T cell disorder, which causes sometimes significant involvement of subcutaneous tissue. It's extremely rare disease. We in our institution see only, yeah, I would say, less than 5 new cases every year. And as I mentioned, key is to recognize it, because diagnosis may not be so easy, because there is disease called lupus panniculitis, and histologically there can be overlap. So pathologists can have sometimes difficulty. We sometimes have to do open biopsy, really, or if you do sponge biopsy, you don't reach deeply enough to subcutaneous tissue, so you have to repeat biopsy. But what is, I would say, even more interesting is that especially in Asian population, that disease can be genetic. You have to, or these affected individuals have to have mutation of both allele of gene called hepatitis A virus cytoplasmic receptor 2, or protein is called TIM3. And uh, practically what that protein does, it's like checkpoint inhibitor. It practically downregulates activity of cells. So if you block this inhibitor of T cell activity, you unleash T cells, and T cells behave aggressively and trigger, and this is considered trigger for that HLH, so this is definitely rare disease. In past, when we didn't know that really you can treat this disease with immunosuppressive therapy, we have used chemotherapy, followed even by stem cell transplantation. But now I would say most of patients can be controlled well with immunosuppressive therapy.
Thank you, Dr. Sokol. That was really informative. Another treatment-focused question here. Can you explain treatment options for ALCL? I have heard treatment can be a mix of radiation and/or antibodies, but don't understand the benefits versus the risk. What is recommended as a maintenance treatment or drug, and how effective are those treatments, and what is the prognosis?
Okay, so primary cutaneous anaplastic large cell lymphoma, again, we have to, or if we get a new patient, we have to make sure that it is not skin manifestation of systemic anaplastic large cell lymphoma. And pathologists have usually difficulties to obviously recognize these two. There are no good markers for differential diagnosis. So we usually, any patients who come with skin lesion, which on biopsy showed that it is anaplastic large cell lymphoma, we stage patient, make sure that the disease is not systemic with skin involvement. Usually, if patients present only with single skin lesion, then best treatment is radiation therapy. We usually don't recommend surgery, because people are sometimes left with really not nicely looking scars. And then it's very hard in this disease to make clear margin so that disease could recur. There are some rare cases if you do good punch biopsy. Before sometimes we see patients back, but lesion regresses spontaneously. Again, that wound activates patient's immune system, and sometimes immune system can eliminate that rest of that lymphoma. So as I mentioned, frontline therapy in this disease, if it's only one skin lesion, is usually radiation. If patient has cluster of few lesion which can be involved in radiation field, you can also radiate. But if patient have more than one lesion, or if a disease metastasized to a local regional lymph nodes, then we often use brentuximab vedotin, which is antibody drug conjugate approved by FDA for this indication. So we usually decide how to treat that patient based on stage. For at least for that one lesions which are limited to skin and can be involved in radiation field, we usually don't use any systemic therapy or maintenance systemic therapy.
Very informative. Thank you so much. My cutaneous lymphoma lesions virtually disappear in the winter, but they seem to be triggered by heat and friction. What are your thoughts on this? Also, as I'm being offered phototherapy, does this treatment trigger skin cancer? Is this worth the risk?
Yeah, it's a very interesting question. Oftentimes, I actually find that my patients flare in the winter, and two reasons for this. One, the disease can be highly sensitive to ultraviolet radiation, so it can be ultraviolet radiation from natural sunlight, which there's an abundance of during the summer, and less so in the winter, or just the humidity in the air can be really hydrating for the skin. So it may make the skin disease less active or less sort of angry in that setting. So I typically find it unusual for it to look its best in the winter. Unless you tell me you winter in Florida, and then it makes perfect sense. And so I would say it's difficult to know what's happening in this specific scenario because it's not, what I typically experience. But for those who do need or are considering phototherapy, the good news is that we have not seen an increase in skin cancer in patients who are on narrow band UVB, which is one single wavelength of UVB light that was chosen because it has the most immune modulatory functions. It can suppress sort of the overactive inflammation and actually be toxic to the lymphoma cells. And so even in my patients who have a history of melanoma, I do not hesitate from using narrowband UVB. I think if you're using narrowband UVB in combination with other therapies or like immunosuppressive therapies, maybe that risk calculation changes. But in general, I do not shy away from it because it can be highly effective and really one of the least toxic side effects therapies. Because again, we're not taking a medication internally, but rather treating the skin from the outside in.
Thank you for that. My husband was initially diagnosed with Sezary in October of 2019. He had an allogenic stem cell transplant in 2020. He relapsed with MF, tumor stage 2B, and large cell transformation. We have done brentuximab, romidepsin, moga, gemcitabine clinical trial for CAR T, and now back to brentuximab. What other recommendations would you suggest for control of this disease, as they have told us we are running out of options in Canada?
Yeah, this is definitely tough situation. I'm sorry that allogeneic stem cell transplant didn't work. We have seen also several patients like this when they originally are diagnosed with Sezary syndrome and then they transform uh, either before or after transplant when they develop practically when the disease behaves more like tumor stage of mycosis fungoides or even acute T-cell leukemia when people can have really 100,000 Sezary cells in blood. The disease is usually really refractory, and not only to biological agents or also even chemotherapy because of gene which is frequently mutated. It's called TP53. So uh, yeah, you mentioned CAR T cell. Yeah, this would be definitely one of option. There is another. Sometimes people can have different CAR T cell, like there is CAR T cell against CD5. If that disease didn't lose CD7 CAR T cell also against CD7. But we sometimes use, if you ask me, do you ever use chemotherapy? Yes, we use in those completely refractory patients. Sometimes there is luck that we can somehow cytoreduce the disease, but unfortunately, there is not too much, evolution in therapy in this area. Sometimes what we do, if patient responded before, say, transplant to certain therapy, we go back and repeat that treatment because it could still it could still work. But then if obviously it's still possible to do, we repeat radiation at least focal if patient develops tumor. So sometimes you have to really improvise based on no data whatsoever, so it's a really difficult situation. But majority, I would say, majority of patients who have Sezary syndrome, I would say at least in our institution, probably 80% do really well if they obviously don't come already with a transformed disease. They can still, they don't need allogeneic stem cell transplant. We usually, if we refer patient for allogeneic stem cell transplant, these are those patients with tumor stage mycosis fungoides more than patients with Sezary syndrome. But there are obviously what I would definitely recommend to look at and talk to your dermatologist or get referred to the tertiary center, because those doctors usually know who have opened good clinical trial if that clinical trial doesn't exclude patients post allogeneic stem cell transplant. But this is a situation where you probably will not have better response than if you go on clinical trial. So this is where I would say, because we, after so many lines of therapy plus allogeneic stem cell transplant, we really don't have data what should be best next therapy.
I would agree
Thank
with
you
Dr.
for
Sokol. Sounds like a very tough case. And again, there's a handful of therapies, and oftentimes we might recycle a therapy, that worked prior to transplant and have it, if it hasn't been tried in the post-transplant setting. Sometimes patients respond better after transplant. With that said, I don't think I saw pralatrexate listed on the medications that they've tried. That's another therapy that we use for burden of disease that's largely in the skin. And the other thing that we've been doing a little bit more of, and I don't know, Dr. Sokol, how much you do this there, but duvelisib, especially romidepsin with duvelisib, has been really
We
helpful
do.
in the post-transplant
We,
settings.
we do. We sometimes combine it with, we had clinical study open with duvelisib plus 5-azacitidine, so
Mhm.
hypomethylating agent. So this could be, again, it's off-label use, but you have to practically improvise. And as I mentioned, best to go to tertiary center where they have more experience, and sometimes you can come up with something what you used 20 years ago even, which worked, and you can use it in your patient. So this is important to go to tertiary center with which is focused on this disease.
Thank you both for that thoughtful response. Next, I was just diagnosed in September and currently have 3 red spots that are fading with steroid cream. Can you comment on 1, how often will these spots come? 2, will I die from this? And 3, will I need chemo if they don't go away? And lastly, 4, do I need to see an oncologist, or is my dermatologist fine until the spots get worse?
Yeah, it's a great question. I think it all comes down to stage. Is it just 3 spots? And so therefore, this patient, I would assume, have stage 1A. And if they're talking about fixed spots in the skin that are, thin to flat, thin spots of mycosis fungoides, which in general, the good news is for patients who present with stage 1A mycosis fungoides, compared to someone who's never been diagnosed with this condition, has sort of the same life expectancy. So it's not something we expect will harm your health. With that said, there's a small percentage of patients that could go on to experience some form of disease progression, which is why I don't recommend observation. I do recommend treatment, because it's difficult to figure out who that small percentage of individuals will be that might go on to experience more active disease. But steroids are really effective, and it's absolutely my first line therapy. I often find that it can take up to 12 weeks, before we start seeing improvement. So it's really encouraging to hear that you're already starting to see some fading in the spots that you have. In terms of what happens next, it's really hard to predict. For some patients, the spots after a really good, intensive use of topical steroids, it might take months. I've had patients where it took years for the disease to come back, but I think the expectation should be that this is something that will come back. And it's not something to get worried about when it comes back, because oftentimes it does behave like this chronic condition that's manageable and annoying, but not something, high alarm, danger that it's going to cause metastasis if we don't clear it, right away. And so in general, I would say that it wouldn't be unusual for the spot to come back, within the year after you've stopped using the steroid cream. And if the steroid cream helped clear it up, you absolutely can go right back to the steroid cream and use it again. So a lot of our treatments are cycling on and off based on how active the disease is. And certainly I would not reach for systemic chemotherapy if it's skin-limited disease. But with that said, there is a gel that is chemotherapy that can be really quite effective for early stage disease. So I hope I covered all the questions.
Yes, thank you. What is your experience, if any, with electron beam therapy?
Yeah, we use it very frequently, and obviously everybody else is using it, especially for more advanced stage of mycosis fungoides. We don't use it in obviously leukemic form, Sezary syndrome, because that radiation will not kill cells which circulate in blood. Very sometimes confusion. People come and say whether they can have total body radiation. Total body radiation is not, this is used in patients pre-transplant, and you have to use very low doses, because if you would use doses we use filled with electron beam, because for total body radiation we use photons, you would practically cause disease of radiation. People would probably die from practically complete damage of bone marrow. So electron beam or accelerated electrons usually are caught in the skin. They don't penetrate to our bone, so you don't cause any low blood counts. You don't need to practically repeat CBC, complete blood count, in these patients. And it's very effective. And what we learn, especially based on Stanford experience, is that we can use much lower doses than we used in past. In past, we have been using like average about 36 gray. Now we are using 1/3, like 12 grays, and we can repeat that total skin electron beam 2 or 3 times. Obviously, if not everybody needs total skin electron beam, many patients need only focal radiation. They may have patch plug disease like flat lesion plus one tumor. So you radiate tumor and then continue with your skin-directed therapy. So it's very, I would say, as for a skin-directed therapy, it is most effective. There is nothing, we don't have any systemic therapy, and I count even in brentuximab vedotin, which would be so effective in treating skin disease. Obviously, it has no effect on usually systemic disease, but for skin disease, we use it. That's why we keep it in our reserve. Say, if we have patients who come and we know is progressing treatment after treatment, we usually don't really, I would say, waste that radiation for a few lesions. We wait, and if we know that that patient, for example, will in future need bone marrow transplant, we try to not to go like over 2 total skin electron beam radiation, because those patients who go to transplant and have to get third one very frequently develops skin complications after allogeneic stem cell transplant if they develop GVHD. So definitely very effective. Except obviously some redness of skin. Usually people don't feel any pain, any significant issue, although obviously again you need to go to center which has extensive experience, because total skin electron beam radiation is one of most complicated program for radiation. So it's better to go to someone who does or who treats a lot of patients with that.
Perfect. Thank you so much. Speaking of radiation, can you talk about radiation treatments for localized areas of MF patches that come and go?
Yeah, I'm happy to take that one. I have to say that I agree with Dr. Sokol. We love radiation because it is so often predictably effective and can give someone a nice duration of response compared to a number of our other therapies. With that said, there is a lifetime limit of how much radiation the skin can get. So it's not something that we rush off and use, especially for early stage lesions of MF patches, unless there's no other effective therapy. For example, if there is an issue with penetration of our topicals based on the type of disease, or if the disease in a very sensitive area like the eyelids, the hands, the feet, where we really don't have months to figure out if this cream is going to work. So we certainly do use it for early stage MF. We have used it for MF, patches. It wouldn't be my first option because, again, there is a lifetime limit of how much we can use. But I do think it can be, really effective when it is used.
Yeah, we use it also in patients, obviously, from cosmetic point of view. If they have so-called folliculotropic mycosis fungoides in face, it can clear it very quickly. And then obviously you continue with other skin-directed therapies. But that folliculotropic mycosis fungoides can be tough to manage even if you combine skin-directed therapy with Targretin or interferon. So sometimes radiation can really help patients, and they obviously feel much better if they can go to shopping or something like that and not have lesion in their face.
Thank you. Another MF focused question. Can you talk a little bit about relapse occurring after 20 plus years and how to manage the mycosis fungoides to keep it from spreading?
Yeah, it's a great question. I think there's actually even a debate in the field about do we use some form of maintenance therapy to keep the disease away? And I think it's a very personalized decision and really depends on really how aggressive or extensive the CTCL was when it first presented. So I think for someone who has been in remission for so long and to have disease come back, I can imagine that's certainly disappointing. But it does happen. And oftentimes when it comes back, it can be managed just as easily as it was, 20 years ago. And so oftentimes we'll use whatever therapy put them into remission, unless there was a reason why they couldn't go back to that therapy, some new risks associated with, other underlying medical disorders. But in general, we tend to treat what we see or treat the disease where it is. And so after restaging, looking at the skin, the blood, making sure there's no other sites of disease, again, there's a number of therapies that could be started. And just because it relapsed after so long doesn't necessarily mean that the disease is any more aggressive. If anything, this is really just, part of the natural history of it.
Great. Thank you so much, Dr. Larocca. Back to stem cell treatment. Are there any alternatives to a stem cell transplant when you really don't want to do it? What is deep remission and how do you get it?
Yeah, and I get that questions from our transplant physicians all the time. But in cutaneous T-cell lymphoma, it's really very frequently difficult to bring them to transplant with nothing on skin, and no even little positivity on PET scan in lymph nodes. It's very, very hard. So I would say first, how to avoid transplant is to not to get that disease, to get to that point you need to do transplant. So I agree with Dr. Larocca. We also, even if patients have few lesions, we don't recommend watch and wait. We try to get rid of these lesions because you never know. It's hard to predict what can happen in patients, and we have seen patients who got stage 1A and within 2 years they really had tumor stage. So we try to treat everybody, and very often in patients who present with some poor prognostic features of the disease, we even put on maintenance somehow to prevent these lesions to come back. But if patients really present with aggressive disease, then I would say right now the only curative options, potentially curative option, is still allogeneic stem cell transplantation. As far as CAR T cell, there is no single product which would be FDA approved for T cell lymphoma. And right now, I don't see any product close to FDA approval. So that success we see in B cell lymphoma, unfortunately, didn't translate to treatment of T cell lymphoma or cutaneous T cell lymphoma. So yeah, there are patients who will present with aggressive, relentless disease, and despite of everything we do, we have to do that allogeneic stem cell transplant. But again, best is to go to tertiary center if you have questions about it and talk to both hematologist, dermatologist, as well as transplant physician and decide whether it's something. We obviously don't send everybody for allogeneic stem cell transplant who develop, for example, tumor stage. Very frequently, if you can control it with, say, radiation and then put patients on maintenance, those patients may be able to avoid transplant, but there are patients who come with very advanced stage, which is refractory or responses. Response duration is very short, so we have to do every few months new treatment, and at the end, nothing what is left is, the only thing what is left is allogeneic stem cell transplantation. So yeah, this happen. It's not free. Fortunately, we don't need to do it very frequently, but there are few patients, and we have, and probably every tertiary center have, who really benefited from transplant. And one more things to say, I always ask if both patients are referred back to me from transplant after you went through this almost hell, would you choose that allotransplant again? And most of patients told me, yes, I would do it. Even those who showed a recurrence. Usually it's local recurrence in skin, which can be again treated with skin-directed therapy. But patients who had really bad disease will tell you that whatever they had to go through is much less than that suffering they experience through that cutaneous lymphoma.
That was a thoughtful answer. Thank you, Dr. Sokol. How do you decide when to go from external or skin-directed therapy to internal medication or systemic therapy?
I think this is a great question, and it kind of fundamentally centers around sort of three, I would say, features. The first would be, how much of the skin is involved, and what have you tried and failed before, and then are there any high-risk features? And so I think for someone who strictly has skin disease, meaning there's no activity in the blood, then, I typically have like a mental breakdown of, is it less than 10% of their body surface area affected? Is it more than 10%? Or from the patient's perspective, how annoying is it to put some sort of cream on the skin? That sort of dictates, what I would do next. For folks who have a lot of spots on the skin where using some form of cream or gel is impractical, phototherapy, again, is a skin-directed therapy, can be a great way of controlling all the disease where the light shines. But for patients where, phototherapy is impractical, where the creams are too burdensome to apply because of just how many spots someone has or because of how thick the spots are, I tend to use some form of systemic therapy. But systemic therapy in and of itself, doesn't have to be a scary medication that's prescribed by the medical oncologist that requires an infusion. It can be an oral medication that you take at home, or even injections like interferon that the patient can give themselves. And so again, it really depends on how much disease someone has on the skin, how thick is it, how uncomfortable are they? Do they want the response faster? And whether or not they can do something like phototherapy. And so again, many, many reasons why to switch to a systemic therapy. And it's not always a systemic therapy with lots of side effects given by a medical oncologist. There are many other options that the patient can do from the comfort of their home that's still a form of systemic therapy.
Thank you so much. And it is 6:15, so we have 15 minutes left, and we want to get through as many questions as we can. So we're going to try to get through as many as we can in the next 15 minutes. And I know so many people have submitted questions, and it's important to get those answers. My initial diagnosis was Sezary Syndrome, and that led to a bone marrow transplant. 7 months later, I have a new diagnosis of cutaneous lymphoma. How is that possible? My bone marrow is working 100% donor cells only. Are you able to shed some light on this?
Yeah, it is. It happens probably in more than half of patients who get allogeneic stem cell transplant that they develop post-transplant new skin lesions. But as long as they don't develop, circulating Sezary cells or bone marrow involvement with those leukemic cells, then that skin lesions can be treated. If it's only few lesions, again, any skin-directed therapy which was used prior to transplant and was effective can be used, and in majority of patients it can work. What we sometimes also do, we talk to our bone marrow transplant physicians and tell them, hey, if patient is still on immunosuppressive therapy, could you somehow reduce doses of immunosuppression? Because in some patients, that disease can really disappear without getting any treatment, because we know that cutaneous T-cell lymphoma is immunogenic disease. So we always talk to transplant first, can you reduce immunosuppression? If not, we go with skin-directed therapy, or we do both at the same time. In most of patients, we can control the disease. So it's not unusual to see. Question could be, is it the same disease now or not? We know that CTCL and Sezary are one of most heterogeneous genetically diseases among all lymphoid malignancies. So I wouldn't be surprised if that disease which came back may have different genetic character than Sezary cells had, but it happens, that we see sometimes different type of presentation, or not completely different immunophenotype, but definitely genetically these recurrent lesions can be different. But it happens in any disease. If you do allogeneic stem cell transplant, it's not 100%. And allogeneic stem cell transplant, as probably transplant doctor explain you, is based on uh, uh, new donor immune cells which will recognize lymphoma cell and kill it. So if those new immune T cells were not able to recognize every single lymphoma cell, then that relapse can happen. But again, if patient can have reduction of immunosuppression, very frequently those lesions can regress spontaneously or together in combination with skin-directed therapy.
Thank you for that. The next question is a two-parter. So first part, I am new to CTCL and have been through 6 months of light treatment and chemo, and was clear for 10 months and then erupted again, followed by treatment with emollient. This eruption was different than the first, and now I am not sure what to expect. How might hot flashes before or during the eruption change or increase the eruption and overall severe fatigue? Second part. Now, being 6 months out, I am relatively clear with no new breakouts and hot flashes are much reduced. What might I expect? I have not been able to see my doctor but have sent photos.
Yeah, I think it's a challenging question because I think the challenge with CTCLs, there's so many things that can cause a rash in the skin. And the question is this rash the disease coming back, or is it related to, some other, medical reason? So I think that would be the first step. But it's not unusual for the disease to come back at some point in time, especially if they've been off therapy, which is a very normal practice. Once we achieve remission, it's not unusual to stop phototherapy or stop whatever therapy that they were on. So if it were to come back, it depends on how much came back, but that would then dictate, whether or not we start with the topical or go back to the phototherapy or some other option. I think hot flashes are tough because it certainly can make you more itchy and more uncomfortable, especially if you have a lot of spots on the skin. So that, is something that, perhaps your dermatologist or a medical oncologist might not be the best person to manage, but in conjunction with, primary care, OBGYN, to help manage some of the endocrine, perimenopausal related side effects, assuming that's what's driving the hot flashes. So it's a complicated question to answer without seeing the rash, but certainly can complicate things when we're going through other side effects.
Sure. Thank you so much, Dr. Larocca. Another derm-based question. As a patient, how does one intelligently differentiate from CTCL on the skin and any other thing that appears on the skin, such as skin cancer, bug bite reaction, or other benign lesion, when applying topicals to the skin and before seeking medical expertise?
This is a tough one because I think this is something that we struggle with too. How do we best counsel you to know when to reach out for help? I would say, in general, CTCL tends to present in a certain way in a particular individual. So if you're someone who tends to get lots of patches or lots of flat spots, chances are a new flat spot is probably the same thing. If you have a new really itchy bump and it's summertime and you were around mosquitoes, there's other people around you that are also itchy, probably okay to wait a couple of weeks to see if that improves or even if a little steroid cream helps. The challenge is that there's sometimes, folks who, even though have had really, wimpy looking disease, might present with a new bump that we would want to treat more seriously or really get that evaluated. So it does come with experience, but I really encourage my patients, especially if your dermatologist feels comfortable, to send photographs. It's easy for us to look at a photograph and say, yeah, I'm not really sure what this is. I need to see you. Or, oh, this is nothing. Give it a couple of weeks to try, one of your steroid creams. So I think when in doubt, reach for help, send photographs. But I do think patients do get better over time once they get a sense what their level of disease activity is and what it typically presents like in the skin. So it's an ongoing conversation.
Great information. Thank you so much. Another stem cell question. At what point does stem cell transplant become a viable option for treatment of MF, large cell transformation? How effective is this treatment approach?
So I would say that everything where we are considering usually transplant, when we have to use more than one systemic therapy, or where the disease practically is starting spreading systemically. This is usually really worrisome because we know that we may be able to control the disease in skin because we still have in our reserve radiation, but that radiation will not be helpful too much if patient have involvement of say deep lymph nodes or even visceral organs. So we, as I mentioned before, we take stem cell transplant really seriously and don't send everybody for it. On top of it, you know that in order to be eligible for transplant, you have to be relatively healthy. And I would say best do people who are really healthy otherwise, don't have kidney disease, liver disease, heart disease, lung disease. So it's pretty selective process to really get through that transplant. So, but if you have a large cell transformation, and we have many cases like that, where you do biopsy on patch or plaque and you find more than 25% large cells, which would histologically qualify for large cell transformation, you don't need to immediately send patient for transplant or start some aggressive systemic therapy. Very frequently, skin-directed therapy can take care of it. Even if usually not all lesions patient have the same histology. You can do 5 biopsy and you will be surprised how many different patterns your dermatopathologist will tell you they see. So if it's really, say, first time you do biopsy on patch plaque disease, very large cell transformation, yeah, we take it seriously, we treat it, but we are not sending patient or considering patient immediately for allogeneic stem cell transplant. If patient develop multiple tumors which are obviously transformed or even non-transformed, then this is patient where we obviously start looking, hey, would this patient be eventually in future eligible for transplant? We treat skin lesion, and if patient is in remission, we still wait, because that patient maybe on maintenance therapy can do well without transplant. But if we say after radiation within few months we see another lesion coming despite of that maintenance therapy, then we really refer patient for at least first transplant evaluation, discuss it, and then we need to find donor, because the disease probably will not be quiet and will be continuously progressing. And I would say worst situation for us as an oncologist is that we almost exhaust every option from NCCN guidelines list, which is like cookbook of all possible treatments. And then we cannot put patient in remission before the transplant. So yeah, again, you need to be seen by doctors who treat the disease, who refer patient to transplant to get best recommendation, because it's more than a large cell transformation. That disease stage, how the disease presents, is it tumor, is it only plaque, make big difference whether you start thinking about sending patient for transplant.
Appreciate that answer. And we have time for two more questions. In addition to a diagnosis of MF stage 1B or 11B, I have chronic blood disorder. I work well with my hematologist oncologist. My dermatologist is associated with a different hospital and practice. They do communicate, but my question is this okay, or do I need my team to be professionally in the same practice? Also, how can I be certain that I'm getting the best care? Do I need multiple opinions?
I think either of us can answer that. I would say that,
Mhm.
so I'm very biased because I work in a team. I work alongside medical oncologists, radiation oncologists, and I think it's very valuable that we all get to see the patient at the same time. But that's very difficult to find depending on where you live. And so, as long as you're being seen by someone who is comfortable managing and knows how to manage cutaneous T-cell lymphoma, and that can actually be a medical oncologist or that can be a dermatologist. It really depends on your stage. I do find that even in my own patients, I'm more than happy and encourage them to get second opinions, because the worst thing you could do is have not have trust in your care team. And sometimes getting that second opinion is that vote of confidence that you needed, and sort of a different way of understanding and learning about the disease that makes you comfortable with their care. And so, in general, I think it can be helpful to get a second opinion. I think teams can be helpful, but it's not always necessary. And it really depends on the stage of disease that you have. If it's really 1B or earlier, sometimes those are typically managed by not just because I am a dermatologist. But if it's 2B, like 2B often refers to tumors in the skin. Often it's helpful to at least have seen a hematologist, medical oncologist who has experience managing the disease.
Great, thank you. With that, I do want to thank you both so much for taking time out of your schedule to share your expertise and answer the questions for the community. And I want to take just a second before we end the program to see if either of you have any closing thoughts that you would like to share.
Yes, I'll
Dr.
go for it.
Larocca, if you want to start.
Yeah. I have to say thank you so much for inviting me here and letting me answer your questions. Again, it is so helpful to hear from patients and their own experiences. And the CLF, I think, is just an incredible resource to help connect with other patients, because I find that patient to patient is the best form of communication to really get help to understand what they're going through, and really when you're not feeling confident, switching to another team for a second opinion can be really helpful.
Thank you. Dr. Sokol, any parting thoughts?
Absolutely. Thank you for inviting us. It's always refreshing to get these questions, because we learn a lot of, because what I learn, maybe I am not explaining the disease really well, because if people have to ask questions, maybe I need to also be more specific when I talk to patients, or be better communicator. And another thing is, I would like to really thank your Cutaneous Lymphoma Foundation, what job you have been doing. We really use your material for your patients, and encourage them to obviously communicate, especially, for example, patients who are scared, and there is it's not surprise, scared of transplant. They can probably, through your society, practically get in touch with patients who underwent transplant. They can discuss with them that issue, so those patients can probably better answer even their questions. So it's definitely a great job you are doing, and we are happy to work with you.
Great. Thank you so much. And thank you to everyone who took part today and submitted questions. It is very appreciated. And before we part, we would appreciate if you could also complete the survey that will be in the chat and also be sent through email. The feedback that we get helps us shape future programs here at the Foundation. And with that, we wish you a great rest of your day. Goodbye.